Welcome everybody. Very good morning. Myself, Dr. Monirul, going to present today Pocket Guideline for Dengue Clinical Case Management 2020. It has been revised in last year, and I must congratulate to my some of great teachers of Bangladesh in the medical science, especially Professor Dr. Abul Bashar Muhammad Khurshid Alam sir, who is the Director General of DGHS, and Professor Dr. MD Nazmul Islam, and another renowned professor who is the main editor of this guideline, Professor Kaji Tariqul Islam sir. So before going to any delay, I will discuss later. The new revised WHO dengue class classification according to severity. The first one is dengue without warning sign, and this patient should be sent to the home for the management. And the second category is dengue with warning signs, that is group B, who must be referred to the hospital care. And the third and final one is severe dengue, and this patient require emergency management. So now the dengue case classification by severity. First we classified it into two categories: dengue with or without warning sign and severe dengue. So what are the warning sign? The warning signs are severe abdominal pain or tenderness, persistent vomiting more than 3 times per day, persistent diarrhea more than 3 times per day, clinically fluid accumulation, mucosal bleeding, lethargy, restlessness, hepatomegaly more than 2 cm, and in laboratory test there is increased hematocrit level concurrent with rapid decrease in the platelet count from the baseline, and those patients who is requiring strict observation and medical intervention. And what the probable dengue case? Those patients who lives in or travel to a dengue endemic area like Dhaka, fever and two of the following criteria like nausea, vomiting, rash, body aches, joint pain, tourniquet test positive, which I will discuss later, leukopenia in complete blood count, any warning sign which I have already mentioned, and the laboratory confirmation of dengue. And criteria for the severe dengue is severe plasma leakage leading to dengue shock syndrome, fluid accumulation with respiratory distress, and sign of severe bleeding, and there is severe organ failure or involvement. In case of liver, there is AGPT level more than 1000, patient has impaired conscious level or any other organ involvement, and there is metabolic and electrolyte abnormalities. So dengue must be classified into two categories. First one is dengue with warning sign and dengue without warning sign, and another classification severe dengue. So what are the sign of severe dengue? There is evidence of severe plasma leakage, severe hemorrhage, and severe organ failure. Now the clinical management. Usually dengue patient admitted to the hospital or came to the doctor's chamber with symptom and without symptom. If asymptomatic, patient maybe go to home and can take the home management. If symptomatic, then patient should classify it into further three groups: group A, group B, and group C. What are the group A, B, C, which I have already mentioned? Group A, which is mild dengue fever, and it is called by another name undifferentiated dengue fever. Fever without complication like bleeding, hypotension, or any other organ involvement, and without evidence of capillary leakage, and this patient should be managed in the home. Now the second category, which is group B or moderate dengue fever. First we must look for the warning sign. If the dengue patient presented with warning signs or the symptoms with or without minor bleeding, then the patient should manage with close monitoring in the hospitalization. And dengue fever with high risks of comorbid condition like infant, old age, diabetes mellitus, hypertension, pregnancy, coronary artery disease, hemoglobinopathies, immunocompromised patient, patient is taking chemotherapeutic agents, patient on steroid, anticoagulants, or immunosuppressant should be hospitalized and advised for close monitoring. And severe dengue, that is group C, that is dengue fever with significant hemorrhage or dengue fever with significant hemorrhage with or without shock or dengue shock syndrome, and severe organ involvement as well as metabolic abnormalities. This patient must be hospitalized and managed in a tertiary care level. Now the clinical presentation of dengue. Dengue presented with classical dengue fever, presented with dengue hemorrhagic fever, that is features of hemorrhage like petechial rash and epistaxis, excess menstrual bleeding, and so on. And another presentation is dengue shock syndrome. Patient may present it with shock, and some of the patient may present it with expanded dengue syndrome, that is multiple organ failure like hepatic failure, liver failure, or kidney failure, dengue myocarditis, and etc. Now, what are the clinical features of dengue fever? Patient may present with severe headache, myalgia, arthralgia, bone pain, and some of the people says that it's like a breakbone fever, and rash. There are some ZT manifestation, nausea, vomiting, diarrhea, and in recent time diarrhea is seen commonly. And what are the hemorrhagic manifestation? Patient may present with mild or unusual hemorrhage or petechial rash. And on blood picture there is leukopenia, WBC count is less than 5000 and platelet count may reduce less than 1.5 lakh. And rising hematocrit 5 to 10% from the baseline. Now the diagnosis, tourniquet test positive plus WBC count less than 5000, which has positive predictive value 83%. If somebody has positive tourniquet test as well as WBC count less than 5000, he or she may have dengue fever around 83% cases. So what is the tourniquet test? We all know it is a WHO standard in bedside test which is done to the suspected dengue case patient. So how to do a tourniquet test? Take the patient's blood pressure and record it. For example, the patient has blood pressure 100/70 millimeter of mercury. So we'll inflate the cuff to a point midway between systolic and diastolic blood pressure and maintain for 5 minutes. So if we think that patient has the blood pressure 100/70 and do a average in between the point of systolic and diastolic blood pressure so that it is 85 millimeter mercury, and in that pressure we will inflate the cup for the 5 minutes and the pressure is released for at least 1 minute and the skin below the cuff is examined for petechiae. Look at the picture. There are multiple petechial rash of the patient in the cubital fossa. So what is the significant finding of tourniquet test? A finding of 10 or more petechiae in 1 square inch area considered positive test. In dengue hemorrhagic fever, the test usually gives a definitive positive result when there is 20 petechiae per 1 inch with a sensitivity of more than 90%. So this is very much important. Now the dengue hemorrhagic fever, patient has clinically high continuous fever for 2 to 7 days. Hemorrhagic manifestation, evidence by tourniquet test positive, petechiae, epistaxis, hematemesis, etc. There may be hepatomegaly and shock. And in laboratory test, there is evidence of plasma leakage. It is rising hematocrit more or equal to 20% from the baseline, pleural effusion, ascites, hypoalbuminemia, that is serum albumin less than 3.5, and platelet count less than 1 lakh. And what are the evidence of plasma leakage? There is rising hematocrit 20% from the baseline. In case of children, it may be from 35 to 42, and in adults, it may be from 40 to 48. And circulatory failure, which is evidenced by cold came skin and capillary refilling time more than 2 seconds, tachycardia, weak pulse, narrow pulse pressure less than 20, and hypotension. There is evidence of fluid accumulation, ascites, and pleural effusion, and albumin is less than 5 gram per deciliter. These are the biochemical evidence of plasma leakage in dengue hemorrhagic fever. Now the natural cause, which is very much important. There is 3 phases of dengue fever. One is febrile phase, another is critical phase, and finally convalescent phase. 2 to 7 days is the febrile phase. In that time, patient presented with high grade continued fever. And in critical phase, which starts from the 3-day, and it is called the leakage phase, and which lasts only 24 to 48 hours. Usually on day 5 to 6, but can happen in the earliest time on day 3. And convalescence phase, which starts after the critical phase and persists 2 to 5 days longer in case of adult. Now the dengue shock syndrome, which I have already mentioned. What are the signs of dengue shock? Patient may present with cold extremities, delayed capillary refill time, lethargy, restless, tachypnea, Kushmal breathing, tachycardia, weak pulse, narrow pulse pressure, less than 20 mm mercury, and hypotension according to age. What is expanded dengue syndrome? It is an unusual manifestation of dengue presented with severe organ involvement such as liver, kidneys, brain, heart associated dengue infection, reported usually in the dengue hemorrhagic fever and also in the dengue fever, who do not have evidence of plasma leakage. This unusual manifestation may associate with co-infection, comorbidities, or complication of prolonged shock. Now the investigation, in case of first day to 5th day of fever, we can do complete blood count, non-structural antigen protein 1 or NS1, HGOT or HGPT, not mandatory but may be helpful. If patient came after 7 days, we can do IgG and IgM antibodies, and day 5 to 7 is a window period. In this time, patient may not have any positive result, and follow-up testing may be done on first febrile day but should be done daily when dengue hemorrhagic fever suspected. Regarding hematocrit, a regular hematocrit is more important for management than that of the thrombocytopenia. It is very much important. We always look for the platelet count, but hematocrit is the cornerstone of the management. In severe dengue, especially with shock, hourly hematocrit is crucial for the management. And now the clinical and laboratory criteria for patients who can be treated at home. Those patients who are able to tolerate orally, good urine output, no history of bleeding, absence of any other warning signs which I have mentioned earlier, and on physical examination, patient is hemodynamically stable, no tachypnea, no acidosis, liver is not palpable or any tenderness, no sign of bleeding, no sign of any third space fluid loss, no alteration of the mental state, and investigation is stable on serial hematocrit. No other criteria for admission. This patient should be managed at home. And what are the advice we will give to that patient who will manage at home? Please take adequate bed rest, adequate fluid intake, at least 250 ml per day, or 8 to 10 glasses of average size adults, or according to children, around 50 ml per kg. Milk, fruit juice, oral rehydration solution, barley, rice, water, coconut may be taken. Take only paracetamol not more than 3 grams per day. Tepid sponging. This patient will be advised to avoid aspirin, mefenamic acid, ibuprofen, or any other NSAID, steroid, and antibiotics. This patient should be immediately taken to the nearest hospital in first febrile day with worsening of the situation or if any other warning signs is observed, and observe the urine output. If no urine output for 4 to 6 hours, go immediately to hospital. Now the fluid management, which is planned for the group B patient. Who are the group B patient I have discussed? The rate of IV fluid for the children according to chart and drop calculation is 40 ml per hour 10 drops per minute, 80 ml per hour 20 drops per minute, 100 ml per hour 25 drops per minute, and 200 ml per hour 50 drops per minute. The easy way of the calculation is ml per hour divided by 4 is equal to drops per minute. If somebody need 100 ml per hour, we will divide it by 4 and the drop will be 25 drops per minute. So that ml per hour divided by 4 is equal to drops per minute. And the amount of the fluid is shown in the chart, and every patient must be managed according to that guideline of the chart. Now the fluid management, which is a bit clumsy, but it should be managed according to that chart in front of your desk or in front before giving the fluid. You must follow this guideline or the chart. And here is another chart which is followed for the profound shock or decompensated shock, and every patient must be managed according to that chart. And if fluid overload happen, what can we do, which has already been discussed in here. I think before managing, everybody must follow this chart. Now the IV fluid. What are the fluids we can use? Two types of IV fluid are used in dengue. First one is crystalloid, which is the first choice, and colloid. An indication of IV fluid in dengue: when the patient cannot have adequate oral fluid intake or vomiting, when hematocrit continues to rise 10 to 20% despite oral rehydration, impending shock. And what are the crystalloid we can use? 0.9% sodium chloride, isotonic normal saline preferable, half strength normal saline in case of children less than 6 months, 5% dextrose in Ringer's lactate DRL, that is 5% DRL can be used, dextrose in acetate Ringer's lactate solution DRA, and Hartmann solution. And colloid we can use dextran 40 or dextran 70, starch based plasma sol, volutin, etc. Gelatin, human albumin can be used, plasma can be used, hemacil, blood and blood component. So the indication of colloid in dengue: patient with massive plasma leakage, patient with shock with rising hematocrit, those not responding to maximum volume of crystalloid, and those blood pressure is less than 10 mm of mercury, those pulse pressure is less than 10 mm of mercury, and who need urgent restore of the blood pressure. So these are the indication of colloid in dengue. And the most commonly asked question: when we give the platelet concentrate? It has been observed that there is very limited role of platelet transfusion. In most of the situation, fresh whole blood transfusion is sufficient. However, it may be required in some special situation, and the indication of which may be as follows: very severe thrombocytopenia who need urgent surgery, and clinical judgment of the treating physician. Now the indication of blood transfusion: if there is overt bleeding more than 10% or 6.8 ml per kg, significant drop of the hematocrit less than 40 after fluid resuscitation, hypotensive shock, persistent worsening metabolic acidosis, refractory shock after fluid 40 to 60 ml per kg. And expanded dengue syndrome, which I have already mentioned in a nutshell, that dengue fever with organ failure like myocarditis, encephalopathy, liver failure, AKI, ARDS, and this patient must be admitted to the hospital, in tertiary level hospital, and managed accordingly. In case of hepatic encephalopathy, we know patient need to oxygen therapy, 20% fluid reduction, colloid therapy, furosemide for fluid overload, lactulose, rifaximin, and fresh frozen plasma, and monitoring hourly blood sugar, correction of the electrolytes, and other metabolic profile. Another issue, pregnancy and dengue, medical termination is to be avoided. MR should not be allowed as there is chance of bleeding. Hospital delivery is advised. Blood should be available. Multidisciplinary team approach. Avoid elective cesarean section and induction of the labor. No episiotomy. No instrumental delivery. In preterm labor, advise delay in delivery. Injection steroid IV to be given for the premature delivery. Misoprostol, tranexamic acid can be given IV. And all dengue patient or suspected dengue patient with pregnancy must get hospitalized. Now, in a nutshell, what we can do: administration of paracetamol for high fever and myalgia, but we cannot do send patient with non-severe dengue at home without follow-up and the inadequate instruction. We can do clinical assessment of the hemodynamic status before and after each fluid bolus and give intravenous fluids or repeat vomiting or rapidly rising hematocrit. Use the appropriate isotonic intravenous fluids or severe dengue in appropriate time and dose. Avoid intramuscular injection. Tight glycemic control in diabetic patient. Give appropriate colloid, packed red cell, fresh whole blood if indicated. We should not administer any NSAID, aspirin or ibuprofen. Miss clinical assessment of patient with respect of fluid therapy. Use intravenous fluids to any patient with mild dengue, those who can take orally. It should not be done. Give intramuscular injection to the dengue patient. It should not be done. Avoid monitoring of the blood glucose. Blood glucose must be monitored. Give excess fluid, blood and blood products. It should not be done. So, this is the dengue guideline in a nutshell. It can be found in Google or in the DGHS website. So, every physician must have this pocket guideline before managing the dengue patient. Especially, the fluid management is very crucial. Every patient must be managed according to the guideline per kg body weight and according to his or her hemodynamic status. Thank you very much. We'll see the next presentation.